Hello, I'm Bruce Kirkham. I'm a rheumatologist at Guy's in St Thomas's Hospital, London, and Professor of Translational Rheumatology at King's College, London. And I'll be talking today about drug targeting in psoriatic arthritis. These are my disclosures. I'd like to really thank Jack and Artie for allowing me the opportunity to talk at this great meeting, and I'm looking forward to joining you with the Q&A later at the end of this session. The agenda today will be, I'll be describing the diverse biology of psoriatic arthritis, describe how our targets, therapeutic targets, pick up different aspects of this biology, and also how these therapies interact with the diverse comorbidities of psoriatic arthritis. So psoriatic arthritis is a real challenge for rheumatologists, which means you have to be a real physician, you have to cope with psoriasis, sometimes very destructive joint disease. You have aspects of spondyloarthritis, also the manifestations of things like nails, but enthesitis and dactylitis, which make the whole thing a very complex and really interesting condition to treat, particularly now we have the tools to do that. So let's talk about a patient. What I'm going to do today is introduce a few patients and try to illustrate points from these patients. So this is a new referral to your practice in your office. So it's a 35-year-old man. He's got a 12-month history of joint pains, which sound very inflammatory. It's relieved by ibuprofen, which he takes at times. He had asthma as a child and significantly had psoriasis at the age of 18. The psoriasis affected his elbows, his scalp, and some nail changes. It was diagnosed by a dermatologist, and he uses topical therapies sometimes to control it, and it's not a major problem for him. He's an office worker, he's a non-smoker, and he assures you that he has a few Budweisers for the games and the weekends, and you estimate he probably drinks about 3 to 8 drinks a week. So on examination, he's a little bit overweight. He's got a body mass index of 29. He has some signs of psoriatic arthritis in his hands, and also around the knee, he's got some tenderness over the patella, which probably suggests he has some enthesitis around there. He has some nail changes, similar to the pictures here, of onycholysis and pitting. And a blood test is negative for all autoantibodies. He has a slightly elevated C-reactive protein, so our normal range is 5, and he has a slightly elevated level of 8. Radiographs of his hands and feet show no erosive changes. So I'd like to ask you a question. So what therapy would you recommend for this young, or this not young, but 35-year-old gentleman? Thanks for the answers. It's interesting because we treat this gentleman with methotrexate. One of the drugs is used frequently in psoriatic arthritis, but there's very little really good controlled studies. And I'd just like to share with you some of the data from the SEAM psoriatic arthritis study, where patients who had not had methotrexate or biologics before received either methotrexate, etanercept, or both. And if we look down at the bottom of the study, this is the MDA, the minimal disease activity. That's really remission in psoriatic arthritis. And you can see that patients who received methotrexate alone, that's the open squares, after 24 weeks, about 30% of them were actually in really remission. If they received etanercept or etanercept plus methotrexate, probably about 40% were in remission. So it does suggest that methotrexate is a good drug for psoriatic arthritis, treating the skin and the nail and the actual joints. So our 35-year-old gentleman did pretty well. He felt better after about 3 months for the skin and the joints. He managed to lose some weight after taking your advice. But after about 8 months, he had some elevated blood tests for liver dysfunction. And this really fits with some really, really interesting data from the Corona registry, published just over 10 years ago, showing that patients with psoriatic arthritis have a significantly increased risk of liver abnormalities with methotrexate compared to patients who have rheumatoid arthritis. And this relates probably to their comorbidities, in particular the increased rate of fatty liver that we see in these patients and the elevated body mass index, which is really one of the risk factors for developing psoriatic arthritis. So psoriatic arthritis is different to rheumatoid arthritis for comorbidities and also maybe for response to therapies. And the biological basis of this is quite important. The genetics are very different. So rheumatoid arthritis, as we know, is related to the HLA-DR and HLA-B and C, the class 1 genes are related to psoriatic arthritis. So this is a really big difference. There's different environmental considerations for rheumatoid arthritis compared to environmental considerations for psoriatic arthritis, which is similar to sort of sometimes you see in psoriasis with trauma and also infections can be related and longitudinal studies related to onset of psoriatic arthritis. And if we look at the other genes associated with it, we see a cluster of genes, and there's a real relationship between psoriasis, psoriatic arthritis, and also inflammatory bowel disease, particularly in genes targeting this. These are T cell signaling. This is the interleukin 17, interleukin 23 pathway in particular. So we can see there's a strong genetic basis for a difference of rheumatoid arthritis and also for an importance of the IL-17, IL-23 pathway. Now, this is a gentleman who's not our 35-year-old man. This patient's got very severe psoriasis and really swollen knees. So I like to think my job is trying to figure out what's going on inside this patient so we can understand the biology and then actually treat the patients effectively. So if we look inside the joint, these are arthroscopic film or pictures of the knee, so that the normal knee is very, very quiet. And in psoriatic arthritis, they have this corkscrew, increased vascularity and synovial thickening. Rheumatoid arthritis, strangely, has this very linear vascularity, and the tissue in the joints is full of lymphocytes. But actually, they're probably different cells are doing different things. And this is one of the findings we did. We were interested in cytokine expression, and you can see that the different things relate probably to TNF being related to a lot of different inflammatory diseases, but in psoriatic arthritis, the IL-23, IL-17 pathway being very much involved, whereas in rheumatoid arthritis, it's probably the IL-6 pathway. And IL-17 was a cytokine described in the 90s, early 90s, and rheumatologists really did a lot of the work in defining the very important roles of IL-17. So before even IL-23 was described, the rheumatologists the biology showed that IL-17 had a very important role in inflammation, but also in causing cartilage and bone erosions, which are key aspects of arthritis. Also, in terms for dermatology colleagues, there was keratinocyte activation. And my group in Sydney in 1999 was looking at the role. We were the first group to actually inhibit IL-17 in an animal model of spondyloarthritis called the adjuvant arthritis model. And we showed it decreased joint swelling, which is anti-inflammatory effects, but also significantly decreased joint damage in this highly destructive animal model of arthritis. So rheumatologists had a very important role in defining the very early aspects of IL-17. And if we look at the timetable, it was described in 1995, in particular by Immunex, who called it IL-17. The rheumatologists were very involved in the 90s in terms of describing IL-17 in inflammatory arthritis. This was our published work here in 2002. In 2003, IL-23 came on the scene and actually started sort of giving us an idea about the control of IL-17. And the IL-23 genetics in 2007 showed that there was a strong relationship in spondyloarthropathy and also in inflammatory bowel disease and psoriasis genetics. Then around here, we started getting placebo-controlled studies of drug, and in 2014, we had the first global approval of an anti-IL-17 drug. So things happened slowly at the start, and I'm pleased to say they improved, they sped up as we got further down the track. So in terms of what we know about this, in terms of the adaptive immune cell, this is T cells like the Th cells and the T helper cells. If you have a naive cell and it gets stimulated and it gets environmental stimulus with cytokines like IL-12 or IL-23, it can go down a type 1 pathway, which is what we see in rheumatoid arthritis, where you get interferon gamma in particular, and IL-12 drives that pathway. If it goes down the IL-4 pathway, you get the type 2 pathway associated with eczema and asthma and relate to IL-4 and IL-5. But if you go down this pathway here, you get an initial stimulus, and then IL-23 drives the cells to the type 17 pathway. And this is the type we see in psoriasis and psoriatic arthritis, and probably in spondyloarthritis as well. If you get a partial stimulus, you get regulatory T cells. So this has been known about, and this is where we've been able to then go forward and develop targeted therapies. And our group in London, working with my colleague Leonie Tams, professor of immunology, we showed in psoriatic arthritis that it's very different to rheumatoid arthritis in what the cells do and what cells are making IL-17. So we have the CD4 cells in rheumatoid arthritis making IL-17, but in psoriatic arthritis, as well as those CD4 cells, we have these CD8 cells here. And we call these TC17 cells. They're cytotoxic CD8 cells. And we showed that these cells here have strong relationships to all of the disease activity measures of psoriatic arthritis in the patients. And this was in real distinction to the CD4 Th17 cells, suggesting that these cells have a very important role. And this led myself and Leonie to put together the biology, the immunology, and the genetics to start to describe what we think is happening. So we've got HLA class 1, which is the HLA-B or C. It stimulates directly CD8 T cells. There's genes which relate to CD8 T cells being more prevalent. There's the genes we were talking about related to IL-23, which actually increase the sensitivity to those cytokines. And then we have other genes up here which are found inside cells like fibroblasts, which increase the sensitivity to interleukin-17 activation. So these cells then get stimulated more and produce a lot of the pro-inflammatory cytokines we see that drive an inflammatory arthritis. So you can see how the genetics and the immunology come together to start describing what's happening in our patients. Now, the other thing we discovered is that these cells are what we call polyfunctional. So these are the cells that make IL-17. This is our TC17 cells here. And you can see that as well as IL-17, they make interferon gamma, TNF, and GM-CSF. And this means that they're very potent cells in the stimulatory in the pathway. Th17 cells, the CD4 cells, are likewise. These make the same sort of cytokine. So these cells really have an important potential role in driving inflammatory arthritis. The other thing is, it was noted quite early on from sort of studies in the laboratory that IL-17 and TNF have what we call synergy. So a little bit of IL-17 and a little bit of TNF causes a very strong reaction. And so we showed that here where the TNF and IL-17 strongly upregulate fibroblast production of things like interleukin-6, interleukin-8, and chemokines, which attract neutrophils and other ways of augmenting an inflammatory response. But also in the joint, IL-17 and TNF both have a very strong synergy in causing joint damage by osteoclast activation. Now, new bone formation is one of the aspects of spondyloarthritis, which is different to rheumatoid. And this, we think, is actually where IL-17 might be having an important role in driving the formation of things like enthesiophytes around the joint and maybe in syndesmophytes in the spine. Another thing we discovered that a lot of these cells making IL-17 are what we call tissue-resident memory cells. So these were first found in mice, but also found in people with psoriasis. And these are memory T cells, which instead of living in lymph nodes where they normally live, actually are found as resident in peripheral tissues like the skin. In psoriasis, which you can see here, there's a lot of these cells in patients with lesional psoriasis here compared to normal skin. And these cells make a lot of IL-17 down here. These are the cells making IL-17. And so we found the same cells in the joints, people with psoriatic arthritis. And what they do is they upregulate activation markers, tissue retention markers, and they downregulate these markers here, which help the cells leave. So they tend to stay in the site, like the joint or the skin, for a long time, and they can be activated and cause a powerful immune response. Immediately they get stimulation. And that's going to be an increasingly important story, we think, in the future. Now, this is a very nice graphic from an article by Chris Richland, and I've included the article along with the the content that goes with this, because I think it sums up how the drugs we use really inhibit. So we're looking at the IL-17 pathway, so this interleukin-17A through F, there's different types of interleukin-17. And we see here that the IL-17 inhibitors we use, ixekizumab and secukinumab, inhibit IL-17A. The new one coming down the track called bimekizumab, it's in development at present, will inhibit IL-17A and F. And brodalumab inhibits a receptor, IL-17RA. And that means that it will actually stop this cytokine, IL-17A, but also could stop other cytokines here, which may be why it works a bit differently to some of the drugs we have at present. We then have the IL-12/23 pathway, and they share this P40 molecule here, which is why IL-12 and IL-23 are both targeted by ustekinumab. But the new specific IL-23 inhibitors, which target the P19 molecule, this part of the IL-23 molecule, IL-23 is made up of P19 and P40, only target IL-23. And also the JAK inhibitors, they target IL-23 by inhibiting the JAK-STAT pathway for the IL-23 receptor. So it gives us a nice overview of how our drugs actually work on this pathway. So let's talk about another patient. So this lady's had definite psoriatic arthritis. She's had it for about 10 years. She's been on methotrexate. For about 7 years. She's been doing quite well, but she's developed some increasing neck pain, which she attributes to an injury she had 4 years ago, but it's very persistent. It troubles her quite often at night and in the mornings. And she noticed in the last 6 months it's quite a lot more stiff, quite a high pain score. When you see her in your office, she's got some sort of slightly active peripheral arthritis, signs of enthesitis, particularly around the quadriceps and around the pelvis, which sometimes can be quite hard to tell clinically, but also her cervical spine has quite limited movements. And you order an MRI and it shows active changes in the spine here, which is almost looking a bit like they call the Anderson lesion, which is a sign of an inflammatory spondylitis. So the question is, again, I'm going to ask you, put your thinking caps on, and what treatment would you use for this lady who's been on methotrexate, has now not doing so well, and has the symptoms of some peripheral arthritis, but also spondylitis? So let's look forward to your answers. Now, the good news is we have some head-to-head studies which help us inform choices, because really we want to give this lady some sort of biologic therapy. And this is data from a sub-analysis of the SPIRIT head-to-head study, which compared ixekizumab to adalimumab in patients with psoriatic arthritis. Some of them had methotrexate and some didn't. And if we look here at, say, the high endpoint of minimal disease activity, this is what I think is like remission. This is ixekizumab doing quite a lot better than adalimumab in patients without methotrexate. However, when we see the patients who had methotrexate, the ixekizumab is still doing about the same, but we see an improvement in the effects of the adalimumab. If we look down here at the endpoint, which was this mixture of ACR 50 and PASI 100, again we see the ixekizumab significantly better than the adalimumab without methotrexate. Whereas if we see the patients here who have adalimumab plus methotrexate, the difference is much more close. So it does suggest that the adalimumab and anti-TNF monoclonal antibody has better efficacy with methotrexate than without methotrexate. And so this is some interesting new data that can put into our formula when we're figuring out what drug for the right patient. Again, we have the data of upadacitinib, the SELECT-1 study, which is patients new to biologics. And we see here, this is the registered dose, the 15 milligram dose of upadacitinib compared to adalimumab in those studies. And we can see here that there's sort of similar outcomes across the board, maybe some slight differences. But if we look at the patients who achieved MDA, again, we have the same sort of similarity around here, about sort of 38%. So this is very useful data to help us get some idea of what the best treatment would be for which patient, and then other things like adverse event profiles and things can drive us. Whereas some areas, cost is also a very important factor, especially in areas where you have biosimilars. Enthesitis is a very important aspect of psoriatic arthritis, and it also links to some of the questions I was talking about with the environmental stress, because as we know, the tendon absorbs a huge amount of environmental stress, mechanical stress. There's also elements where the microbiota could have an effect. And where we can do this, this could actually cause activation directly by stimulating some of these lymphoid cells here in a direct stimulation. These are called innate immune cells, and they can sometimes respond directly to micro damage, micro stress, and also environmental stress, like infection, rather than having to be driven by IL-23. And this is very important, and it does show that there's more than just the adaptive T cells. So these are the kind of cells we think are important sources of IL-17 in spondyloarthritis. We have the adaptive immune cells, we've got the CD4 Th17 cells, the CD8 TC17 cells, and some of them are TRMs, tissue resident memory cells. But we have all these innate cells, innate ILC3s, gamma delta T cells, the natural killer T cells, and the mate cells, which actually called mucosal associated immune T cells, rather than mate cells being discovered from Australia. But basically they all produce IL-17, and they don't have T cell receptors. So they probably have an important role, and we're learning a lot more about them on a daily basis. Now, we think one of the ways they might be helping us explain things is that IL-17 and TNF, both very important in spondyloarthritis and psoriatic arthritis, don't have direct inhibition by JAK inhibitors. And this is a paper that Leonie Tams and I produced recently, where we showed that the cytokines like interleukin-9 and interleukin-17 could be inhibited by JAK inhibitors, and that would decrease activation of some of these innate cells here. IL-22 also could be inhibited by JAK inhibitors, which also may explain the secondary effect of improving disease activity. Now, of course, I mentioned before that IL-23 can be directly inhibited by JAK, but we know that IL-23 inhibition for the spine and spondylitis isn't that great, but we also know that JAK inhibitors seem to be quite good for spondylitis. So some of these indirect pathways might be very important ways of explaining what's happening. So let's turn to our last patient. So this is a male aged 43. He's a long-term patient with psoriatic arthritis. He had for many years. He's failed DMARDs. He's failed a TNF inhibitor. He comes to see you and he's not feeling that great. He's had some previous abnormal liver function tests. He's got issues of mood. He has psoriasis. He used topicals. And you're a rheumatologist, so we say, how are you getting on? How's the skin? Any problems? He says it's okay. But when you see him in your clinic, you realize something's not quite right. He's got a couple of joints a bit swollen, but he's just not feeling so good about things. He might have slightly low mood, but is there another way you could find out what's happening? What sort of things would you want to ask this patient, and how might you find out what's wrong with them? So any suggestions would be welcome. Thank you. So one of the things we want to find out, maybe is this person got problems with psoriasis he's not really talking about? So our quantitative rheumatologists may use questionnaires. There's a very good one called the PSA. There are other questionnaires specifically for skin, which could be used. And they can sometimes find out things from patients who don't really like talking about things. Alternatively, the great thing about rheumatologists is we have a relationship with patients. So you could ask them, is the skin troubling him? You might get this, well, maybe. And then you could be more specific. Do you have genital or psoriasis down below? Or one of those other questions which we've all learned how to work out. And you sort of might get this, well, yes. And what you might be talking about here is high impact site psoriasis. So genital psoriasis is particularly troublesome, but psoriasis on the skin and particularly psoriasis on the hands. These are where the skin is not particularly extensive, but it really causes quite significant problems with quality of life. Now, particularly genital psoriasis is underreported, and in Europe, they talk about some people who really report problems with psoriasis. These are people, they call it alexithymia. It's sort of like a personality type. They do not complain about things, and sometimes they have to be sort of encouraged to really tell you what's wrong. So then we have to look at drugs that are going to have a good effect on the psoriasis as well as joints. And this is where we're looking at the latest data from the KEEPSAKE-2 study of risankizumab in biologic experienced patients. And here we have the PASI 90. Now, PASI 90 has become the new gold standard for patients with psoriasis ever since we had the IL-17 drugs. And we have a very good PASI 90 at 55%. But then again, the ACR 50 is 26%, which is not amazing. Now let's have a look at the upadacitinib data. This is the SELECT PSA2. This is in patients who had previous biologic experience. And here we have the ACR, here we have the PASI 90. It's not as good. It's actually the PASI 90 of the upadacitinib is about 38% compared to 55%. But then again, on the other hand, the ACR 50, here it is here, it's actually 40%. So this is where you actually have to start having a conversation with the patient. What is the problem? How can we treat it? We've got something that's good for the joints or maybe better for the skin. And this is where we can start really choosing the right drug for the right patient. Patient has a really important role to play, but also alternative ways of treating different aspects of the disease. So in summary, I think rheumatoid psoriatic arthritis in 20 years has come from being transitioned from a Cinderella condition where there was almost no therapies and no real studies of effective therapies, to now where we have a wide range of highly effective therapies and much better idea about what's going on. We unfortunately have no biological markers to identify responders to specific targeted therapies, but we know that the heterogeneous nature of the clinical effects and adverse events can really start to give us an idea about which drugs are the right drugs for our patients. And this is where we have to be real physicians and talk to our patients and work out what are the priorities. So I look forward to joining you at the end of this session. Thank you very much.